the better I can. But so I'm going to focus more in the practical stuff of telemedicine, what we have learned, and what are we doing now? Because we have been doing this for many years. I don't have any financial interest in this presentation, and I like starting with this COVID-19 break, that it really changed the way we do things. It speed up many processes. It was really tough for the world. A lot of people passed away, and many beloved people left. But there are definitely some changes that are going to be positive after this, and that they are going to improve the way we do things. We are going to be much more efficient. We're going to spend less time in things that are not important, and we're going to enjoy more things. And one of the really real things that I believe they are going to change and improve a lot are the unmet needs in medicine. Why I'm saying this? Because medicine is one of those scenarios that are definitely going to change, because a lot of money is being spent there. There are hundreds and hundreds of startups willing to change and improve the way we are doing things. This pandemic has come here in a time where standards were never discussed in medicine in general. And now with the pandemic, everything is a little bit more relaxed. We were able to do telemedicine with WhatsApp. The EMRs are rising and are adding more value to what they used to do, and many other processes. So hundreds and hundreds in all the fields, which is very positive. Going back to the topic that I have to speak, of course, is telemedicine. Telemedicine was absolutely everywhere in the pandemic, in every single specialty in medicine, not only in ophthalmology, and even, of course, for dogs, for veterinarians. So it was absolutely everything. But what do we used to do with before this COVID-19? So telemedicine was already applied in more than 3,500 service sites in the US, and over half of all US hospitals have some form of telemedicine. What are the bad news? The bad news before this pandemic were there were just a few projects regarding telemedicine. There were a couple of ROP screening, DR screening, and glaucoma screening in some Walmarts, AMD screening, but not more than that. So the question is, what happened with refractive surgery? Where's refractive surgery? Because we can all infer that after all this huge crisis and all these new publications, peer review, after 2019, after this pandemic, will involve refractive surgery. No, the bad news is that there's nothing specifically on refractive surgery. There are some very superficial, speaking about corneal screening, but nothing on refractive surgery. So this is a question that I like to attack after with you guys in the discussion, but this is something that has to leave us thinking on this. So we have all the positive, the wing tail. We have patient and provider interest. We have a relaxation of regulatory restrictions, and we do have increased remote care reimbursement. So we have everything positive to start doing this. Most of the EMRs that are being used have solutions, and the ones that do not have any connection, you can use it outside. So there are many solutions to do telemedicine. It's not an excuse. And now we have many easy to apply solutions like this. I have no financial interest. It's a project from a guy in Argentina. It's very good. They are all based with smartphone. That is our biggest tool here. You can see how you can set it up very fast at any slit lamp in the world. There are no restrictions, and it's very easy. And if you want a little bit something more fixed, more sophisticated, you have this project from a Colombian guy living in Germany, which is amazing, that is custom surgical, which is very nice too. So we do have the possibility even to be inside our operating rooms with this click and fit technology. So every solution, it's very, very different to what we used to do, what Giselle and my father started more than 20 years ago. Everything was very expensive. They struggled to have the best cameras, the best equipment, to have the best patient experience. But now look at the pictures that can be taken today. These are all smartphone pictures. You can clearly see here in the right, the keratitis. You can see this opacity in the cornea. You see this corneal ring. Everything is very precise and high definition. These are all pictures taken by the smartphone, which means that there's no need today to have a very complex system. It's all a matter of how you set it up, how you train your staff, and how you spend the time, the correct time, standardizing, as Dan Reinstein said, standardizing luminosity and everything to get these spectacular pictures. So this has been proven to be very specific, to have a high specificity and high sensitivity. So besides the cost saving, which that they are not something to miss, because this is really one of the most important benefits of telemedicine. I do think that it's much more than that. This is taken into account with expensive equipment. But the most important thing for me is that there is no difference in patient perceived utility. And that's very important. And more if we are thinking in someone that has to elect an elective procedure, to have to pick something to stop using their glasses and correct their vision. They have to feel safe. They have to trust the system. And that's what we have always experienced in the Institute. My conversion rate has always been or equal or better with telemedicine than being live. So as I told you, we have 21 years of experience in the clinic. This started in 2001 in this back and forth with patients. There was one of the 100 economic crises that we have in Argentina every 5 or 10 years. And most of our patients come from Buenos Aires. My father had the necessity to be closer to those patients, being having the highest conversion rate in the clinic. He had this time after doing surgeries to convince patients. And this is mainly what we have been doing in these 21, 22 years. From 2001, we are doing the same, but improving, of course, the flow and everything. And this is what I want to share at a glance in a very short time, at least to feel what we have been doing and to apply it in your places. So if I have to put the 10 more important points on digital transformation: safety. Patients have to feel safe, feel that you are really analyzing exactly their eyes. You cannot say, I'm not seeing very well. Do you have a bad connectivity? They have to look at you and say, oh, everything is perfect. So in order to everything be perfect, you have to take into account details. As it was mentioned before, it's engineering surgery, where here is engineering imaging. You have to have perfect connectivity. Your equipment has to be, everything's perfectly set up. Everything has to be smooth. Engagement, be engaging with your patient, have images, simulations, show them images. It's like a presentation. We are used to do webinars every day. So don't pretend to have a regular standard conversation with the patient. Try to act. It's like a scene of a movie. Satisfaction is very high. It's very convenient by their patients. They don't lose time. And sorry if I'm just anticipating my next couple of slides. Today is much more convenient than they used to be before, because they are not losing time at the examining room. It's much more productive for doctors, for patients, for everyone. It's accessible, it's efficient, and something that is a door opener is we will be able, if we apply this in a more smarter way, we will be able to see patients together, to have collaborative care, and to share knowledge. So very fast, in order to finish in time. There are 3 very big groups here. Teleorientation, that has been applied a lot during the pandemic, and unfortunately, it has been abandoned in most of the sites that I know. immersive telemedicine, that is what we have been doing many, many years, that it can be synchronous, that is seeing the patient in real time, or asynchronous, that is what we are doing, and non-immersive. So basically, immersive telemedicine is feel that you are exactly an extension of the other room. We have same colors, same table, the patient is seeing you at your same size. It's an immersive concept. So you might know this guy, this Diego Maradona, was one of my big patients and big fans of telemedicine. So I had a chance to see him many, many times. And I diagnosed him a cataract, and we performed a cataract procedure on him through telemedicine. So this is not only for poor people. Everyone loves it. It's all about the experience that you create. So this is the Cisco story. We are part of a Cisco success case of this application. And I'm not going to spend time on the flows, just tell you that we divided this in 3 parts. The overview and EMR screening, where we check all the data that we have on the patient. We have all the studies. This is what we used to do. The patient encounter, where I have a well-trained technician or OD or a general ophthalmologist, the resident, showing me the eye, and I'm in the other eye. And we discuss with the patient and decide for the best idea. Always, I like backing up with images, fundus camera, retinal image, and OSI, objective scatter index, and some exams for dry eye. Always good. I'm going to go very fast, not to pass a lot of my time, but I converted 92% of the patients to premium, compared to 27% to 73% of the other doctors. So that was the reason why I started doing this with all the patients that were interested in having a procedure, having them listen the explanation. So it's kind of, you are doing both ways, both things at the same time. You are talking to the patient and you are teaching someone. So I'm just going to go fast, very, very fast. Pros and cons. Miss real-time details if staff is not properly trained. This is something very important. If you are not doing this in a synchronous way and you're doing this with only with a recorded image, sometimes they are not focusing ideally in where you would have checked, having the opportunity to command the slit lamp, and the optimization of specialists. This is very, very important. And there is no advantage on flow and time consuming. This is regarding the synchronous. And this is what I want to touch base now. So let me go forward. So now what we are doing, and to be honest, I inspired Neda Nikpur that is there. Neda is a very smart girl and she got it very fast. And she made a comment, and then I started doing this in 100% of my patients. So I'm doing a modular assessment. So far I've seen 2,464 patients this way. And the way I do it is very easy. The patients get to the clinic. We have a series of examinations that we want to do. We want to check absolutely everything. We do the OSI, we check the clinical status, performance, and everything. That patient, that's uploaded to our EMR. I check the EMR, I see absolutely everything. And another day, different day, the patient from his house, with his family, with a coffee, very relaxed, we just talk and spend time together analyzing their talk and everything. This is a modular way. It's something that in Bascom Palmer they say hybrid. We have been doing this and it's extremely successful. Sometimes I can even optimize my diagnosis, because if I have doubts in what I'm seeing, I just do first, before doing the consultation with the patient, I just ask the specialist, the retina specialist, what do they think about this? And I earn time for the patient, because at that point I'm giving them a whole decision on their case without having to send him to another place or before seeing. So just, I'm going to finish here, not to make it so long. I think this in the real world, where you have been showing, in most of the places can be applied. there is a scarcity of specialists everywhere, and this is a way to get the specialists to analyze and to add value in places where it can be performed. There is a huge difference in amount of ophthalmologists all around the world. Argentina has one of the highest in the world with 138. And for you to take into account, China has 20 every million, and US has 59, UK 49. Of course, you guys have ODs that we don't have ODs. That's the reason why you have, when you put both together, you have pretty similar to Argentina. But there are places in the world like Ethiopia and other places that have less than 5. So this is the things that we should start envisioning how we can deal with this. As a conclusion, I'm leaving it to a discussion. I'm not going to repeat all these strategic points that I touched, but I think that modular telemedicine is a valid option for refractive focused practices, higher conversion rate and better patient care. And I think that if we are really committed to cure world blindness, telemedicine should be part of that strategy. That's for sure, not only for screening, for pre-op assessment, for teaching, for mentoring, and for post-op. I think when we think in the amount of time that the patient spends for a post-op, the amount of visits that they have to do, if we can improve all this flow, it will make it easier, us having more surgeons and everything, but it's part of the problem. With this, I'm going to finish and leave it for discussion. Thank you, Ashiana, and all the organization.